It's Dr. Sabrina Siegel here with a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts with 1 part released each month. The next theme is on Alzheimer's disease, the amyloid hypothesis, disease modification, and breakthroughs in diagnosis and treatment. Today, Dr. Andy Cutler interviews Dr. Kostas Lyketsos about precision medicine and behavioral modifications for Alzheimer's disease. Let's listen in to part 3 of our theme, Beyond the Amyloid Hypothesis, Prevention, Management, and Treatment of Alzheimer's Disease.
Hello and welcome to another episode of the PsychopharmaStahlogy Show, an NEI podcast series with the inimitable Dr. Stephen Stahl. Today we are doing another podcast in a series that we're doing on Alzheimer's disease, and it's an area that's very hot with a lot of research. We all know about some of the newer treatments that are coming out that are focused on amyloid. They're antibodies against amyloid. And with us today we have a very special guest, an old friend of mine, Dr. Constantine Lyketsos from Johns Hopkins. Kostas, how are you today?
Andy, I'm well, thank you. And I'm delighted to be talking to you today about this topic that's near and dear to my heart.
It certainly is. You have been at the forefront of geriatric psychiatry for quite a few years now. And I guess the question is, let's just sort of start. We've been researching Alzheimer's for quite a long time. A lot of money has been spent on this. We've certainly made some advances in our understanding. Where do you think we are now with respect to understanding the illness and ideally to getting better treatments?
Well, Andy, I think we have had a number of advances. I think one of the critical things that we've accomplished is good epidemiology to help us understand the variables that impact the progression of Alzheimer's disease. And that has allowed the development of a variety of packaged treatments, or we sometimes call them dementia care or memory care, that have their own independent benefit for patients. So I think we've got to remember that the care and treatment of patients and caregivers relate to Alzheimer's and related conditions. It's much better now than it was many years ago because of all these advances. It's better just because diagnosis is better and more accurate. It's better because a sense of hope has been injected into the whole process. And so patients and families know, at least the ones we see, that there's something to be done. There's something to be done that's very effective. So from the care point of view, from the quality of life point of view, there have been considerable improvements. Where we've not made huge progress is in developing what you might call a curative disease-oriented therapy, essentially a process or a treatment that will take away the disease from the brain. But in that regard, I think we're no different than where we have been with other psychiatric conditions. So I think it's definitely lots of room for improvement. The other thing that we've learned in the last 40 years is Alzheimer's is not just a memory disorder. It's a condition with very frequent psychiatric symptomatology, ranging from depression to agitation, to delusions and hallucinations. And in our ability to effectively treat that group of symptoms, there's also been a fair bit of advance. So especially in the last 10 years, we've moved from simply importing antidepressants and antipsychotics into this area to having a really better targeted approach. How do we use antidepressants? How do we use antipsychotics? For whom and why? What are the outcomes we can expect? We're also now seeing a host of new pharmacologic therapies from classes of drugs that we didn't expect before as being useful in this area. So a big improvement in treating neuropsychiatric or behavioral and psychological symptoms.
Well, these are certainly very important, the neuropsychiatric and neurobehavioral symptoms. These are the things that end up getting people into trouble, into institutions, hospitals, and nursing homes, and so on. I think that is a useful stratification to think about attacking the illness itself, ideally a disease-modifying treatment, versus treating the complications, including neuropsychiatric. And maybe we are a little further along with the latter than the former. But it sounds like you have a little bit of hope for what we may be able to accomplish.
Yeah, I do have hope. I think the hope comes mostly from two areas: that we now have better tools to measure what's going on in the brain when we can't directly see it. And I think that'll help us improve differentiation of different types of Alzheimer's. I don't think it's one disease. And targeting therapies in the very crucial pre-symptomatic phase. So we've learned that whatever we see in the form of symptoms, whether it be the cognitive symptoms, the functional changes, the neuropsychiatric symptoms, those are the iceberg that emerge after what is probably a prolonged process of degeneration in the brain. And that process where we have no symptoms is what we call the pre-symptomatic phase. A lot of effort to modify the brain or symptoms after symptoms have started has come across the fact that, if you will, brain damage has occurred, which is very hard to reverse. So the shift to the pre-symptomatic phase allows us to try and interfere or modify the underlying disease processes, whatever they might be, before there's enough brain damage, which takes on a life of its own. So my hope comes from working the pre-symptomatic phase, either with targeted disease-modifying therapies that are starting to come out, or with very important preventive activities, which have a lot to do with lifestyle more than anything else. Things like nutrition, exercise, and good sleep, getting depression and anxiety managed, not necessarily disorder level. I think that's where the hope is coming from for me.
Well, if you don't mind, I want to dig in a little bit to these things that you're talking about before we start talking about targeted therapies, maybe disease-modifying treatments. I don't think we talk enough about some of the things you've just mentioned. And so perhaps you could give us a little bit of what is the evidence base for maybe some specific nutritional and lifestyle interventions.
Yeah. So the evidence base is primarily observational epidemiology. A few trials, because they're hard to do. The observational epi, if you wanted to look at the nutritional side, for example, pretty consistently suggests that something called the Mediterranean diet probably attenuates the Mediterranean diet. Well, you know, I'm Greek, Andy. It's what we eat in my native land.
That's right.
A diet rich in fruits and vegetables, very little red meat. So I think that observational epi says Mediterranean diet is probably a good thing. The most consistent, impactful signal is in the area of exercise. Exercise is good for the brain, especially if it's a combination of aerobic and non-aerobic forms of exercise. So I think we put a lot of emphasis on that as well. But then very important study done in Scandinavia, known as the Finger study, the F stands for Finland, where this was done, suggested that things like socialization, staying active socially, mental activity make a difference. You know, a colleague of mine used to say your risk of Alzheimer's is inversely proportional to the number of New York Times crossword puzzles that you do every Sunday. And there's a little bit of truth to that. So I think of that as the keeping your brain active through exercise, through staying engaged socially, and also through staying engaged mentally. In general, people are lower risk for dementia and have a better outcome for dementia if they don't have other morbidity, if their vasculature is working well, if they take care of themselves. So I think it's, you know, those three areas of activity, good health, Mediterranean diet is a pretty good package. Not easy to do.
Yeah, no, I think you're absolutely right. I mean, I'm familiar with some research that shows, for instance, if you manage hypertension, cutting out smoking, excessive alcohol, but also diabetes and being overweight, managing weight, which can lead to inflammation. Diabetes, as my friend Roger McIntyre says, metastasizes to the brain and is bad for the brain, as is inflammation in all forms. So I think the things we're talking about here, we know that exercise, for instance, is very anti-inflammatory. It, of course, strengthens vasculature. Subserving the Mediterranean diet, of course, has antioxidants and anti-inflammatories. And of course, we have to add, there's literature on berries, of all things. For some reason, blueberries seem to really come out well in these analyses. But berries and things full of antioxidants, nuts, and healthy oils, as you mentioned. So if we were talking about treating diabetes, we'd of course be talking about lifestyle interventions in addition to insulin and other treatments. And for some reason in psychiatry, I don't know that we always talk about brain health and how health for the body affects the brain.
Yeah, I think we should in psychiatry talk a whole lot more, not just because of the obvious, but because I think as clinicians, we have the tools to help people implement things. I think in that regard, because understand behavior, we understand psychology, and we're able to persuade people. I think we can be quite impactful getting them to do the right things.
I think you're right. And I think we develop very strong relationships with our patients. There's something, the intimacy of what we do, I think lends itself to being trusted and perhaps to being influential in people's behaviors.
Yeah. Very true.
I wanted to circle back, if I could, on something you touched on, which is socialization. I mean, clearly mental activity, I agree, that makes sense. You don't use it, you lose it. But, I think there's a growing literature now on the importance of socialization and the damaging effects of loneliness in all ages, of course. But as people start dying, we lose friends, we lose loved ones. And I think this can really magnify the problem to some degree.
Yeah, I think that's right. Perhaps again, my perspective of having grown up in Greece gives me a little bit more insight here. The kinds of social networks people tend to have in the U.S. are different than the kinds of social networks you have in, say, my native country. So the point here is that in the U.S., we tend to be focused around a nuclear family, tend to socialize with people from work. We don't have this sort of extended network of close friends and acquaintances, seeing them regularly, going out regularly, not engaged as much other than religious institutions, not engaged as much in community organizations. So I think that side is not just combating loneliness, but it's the active, there is a social brain muscle, if you will. I can't quite tell you where it is, but the concept that you keep your brain active, not just because you exercise, not just because you read or you're mentally active, but because you're putting it out there in a social context on a regular basis. So I think he is very much a use it or lose it, and that the social brain needs to be fed and maintained.
So as we're talking about loneliness here and how, of course, our social networks are different, I also worry about the rise of social media, which I think is a double-edged sword. Of course, for some people, it may be a form of social connection, but it's not the same as in person. And I do worry about the effects of social media and how it could be worsening our loneliness problem.
Yeah, I think you're right. I mean, social media and distance relationships are easier in some ways. You don't have to put that much effort in to organize them. You don't have to put effort in getting to wherever the interaction is going to take place, so you lose that part. But I also think the quality of in-person is very different. It's funny because the pandemic, my sense of the quality of patient care I could deliver in person or telemedicine, I was thinking I could probably do it just as well through telemedicine. But I'm convinced now that some aspect of being in the same room with a patient that is very important and cannot be delivered through telemedicine. But I think that same thing applies to the social context of our interpersonal lives, that we need to have, or it's best that we have these in-person interactions.
Yeah, I very much agree. I think our brains are wired for in-person social interactions. I think our brains pick up on things, nonverbal things, gestures, mannerisms, perhaps even auras, smells, pheromones, whatever. But I think that there's a lot of communication going on in the room that you don't get from a two-dimensional interaction.
Exactly.
All right, let's shift gears a little bit here. Thank you for that. I think that was really fascinating and helpful for our audience as clinicians. I hope people remember to pay attention to the basics that we've been talking about. But let's talk about now some of the research that you're involved in. And maybe you could talk a little bit about some of the blood biomarker research that you're involved with at Hopkins.
Yeah, let me take a step back to put it in context. So at Hopkins, we take the idea of precision medicine as applied to Alzheimer's very seriously. And our premise is that Alzheimer's is not a single disease. So the idea for precision medicine for us in this context is what are the tools that will help us differentiate the different subtypes of the disease that are relevant in that way? So a lot of the blood biomarkers are geared in that direction, which is a little bit different than what some of the emerging commercial biomarkers are all about. There are emerging commercial blood biomarkers that will allow us in the next year or two, I think, to measure key proteins like phospho-tau or amyloid in the blood. It will tell us something about how the brain's doing, how the disease is progressing, or even help us with diagnosis. What we're doing is a little bit different, and we're working really in two spaces, which overlap. The one space relates to these tiny little lipid particles that every cell produces called extracellular vesicles, or EVs. I'll call them EVs from now on. Every cell of the body produces EVs of various sizes. EV science is in its early days. EVs themselves might be a means of cells getting rid of trash, might be trash bins. They might also, probably also are means that cells communicate with one another, et cetera. But the key point here is that when EVs come out of a cell, they have two characteristics. They have surface markers, and these surface markers reflect the cell from which they came. And they also have what's referred to as cargo, which basically mirrors in some way the cytoplasm of the cell from which they came. Our idea is that this could offer a very important look into brain cells. And so the science that we're trying to develop, in many ways, I'm not doing it. I'm not a basic scientist, but in our translational model, we work with the basic scientists who do this work. We're basically trying to characterize EVs in the blood based on what cell in the brain or what type of cell in the brain they came from. And then once we do that, to measure what's inside them. So you mentioned, Andy, inflammatory state. One example would be if we know that a certain class of EVs in the blood came from, I'm throwing out an idea now, dopamine cells in the brain, and we can measure how inflamed those cells by looking at the inflammatory state of the EV cargo. So you can take that idea and expand it to many other places. You can go to serotonin cells. You can go to glutamate cells. You can go to other brain cells that are not neuronal. You can go to astrocytes. You can go to microglia, which are the main inflammatory cells. So our interest then is to develop knowledge about blood tests that pull EVs out of the blood, whose address we know and whose contents we can study.
Let me be clear for a second. So you're saying that these EVs end up in the bloodstream, so they've crossed the blood-brain barrier, and it's almost like a window into the brain.
Yes. They're teeny little lipid particles, and how they cross from the blood-brain barrier is variable. But yes, that's a point I should have made clearer.
No, this is remarkable. I have to tell you, this is going to be new. It's new to me, and it's going to be new to a lot of our audience. So I think this is very exciting.
I agree. It's very exciting. Let me couple it with the other exciting thing, which is stem cells. So in general, the idea about stem cells has been that they're hard to develop. It has been that stem cells ultimately will be about delivering a therapy. So the stem cells will correct some kind of defect that we have. So they will deliver a component of the body that doesn't exist. And there are many diseases where this is going to happen. And the other idea about stem cells has been that it's really, you just need to use one or two people's stem cells to develop a model that you can then develop and introduce to someone as a therapy. We're looking at the stem cells very differently. First of all, the technology is very advanced now. So the ability to draw blood, extract PBMCs, peripheral blood mononuclear cells, and the term is reprogram these into stem cells, is now pretty standard. Expensive still, but standard. So Andy, if you stop by Basa Macheraki's lab at Hopkins next week, she could draw your blood. And she could have your own stem cells growing in a dish about a month later.
Oh my goodness.
Now, what do we do with those stem cells? So now we can do that. We could all be giving our blood and having our stem cells archived somewhere in the bank. What do we do with them? Well, stem cells, and here's another term, is they are differentiated. That's the essence of the stem cell. You can turn them into pretty much any cell of the body that you want. Complicated techniques, not cheap, but again, conceptually well proven. And my colleagues at Hopkins have made them into many different types of brain cells. Now, of interest to us in psychiatry are serotonin cells being one example. So now, Andy, you and I could have our serotonin brain cells growing in a lab somewhere. And what do we do with them? We can study them in different ways. We can measure, for example, how your serotonin cells versus mine, if they're just in culture, how much serotonin are they making over time? Do you and I have equally efficient serotonin producing cells? But we could also add drug to them in culture. We could take an SSRI, there are many, and see whether everybody's serotonin cells in culture react equally to a standard dose of an SSRI. And this might tell us whether this SSRI is better for you from a pharmacodynamic point of view. Because right now, the tests we have for kind of efficacy are largely pharmacokinetic tests.
Right, I agree.
So that's the other major direction, is understanding the value of blood-derived stem cells created into brain cells, in both them serving as biomarkers, but also serving as potential drug platform, where we can assess whether individual drugs are best suited to individual people for a particular purpose.
My goodness. You are blowing my mind.
Well, you pull the two together, by the way, and this is a small detail, but an important one, because you might say, how do you know the EV in blood, where did it come from? Well, you use the stem cells for that. So stem cells in culture, back to the serotonin idea, because that's where the work is most advanced. We now know what EVs a serotonin cell is producing in culture. So can we go find those in blood? And if we can, then we'll be able to say that in your blood and my blood, we can draw it and we can isolate your serotonin origin EVs.
I mean, I can see so much potential for this. It's remarkable to better understanding disease processes. But more importantly, the holy grail is, of course, precision medicine, which is finding the best for you. I talk all the time about in oncology, our colleagues in oncology can do tests and find out tumor markers and what's the best chemotherapy for your particular type of tumor. We're not there yet, but it sounds like we may be knocking on the door of something like that.
We are hoping that. And listen, it's not just us that are doing this kind of stuff, but it's these technologies now are being studied all over the world.
Yeah, I mean, this is really incredible. So, I can imagine applications of, obviously you're talking about serotonin. Of course, that makes me think mood disorders. But if we're talking about Alzheimer's, I can imagine also things like vulnerability of these cells to specific environments or toxins or things like that. Understanding perhaps genetic differences between your astrocytes and mine, or your neurons and mine, things like that.
You're
that
catching would lead on. To, yes.
Yeah. Yeah. Well, I think a lot of us are going to have to be catching up to this kind of technology. It's pretty remarkable. Well, obviously, Kostas, I can see from these space-age technologies a lot of potential. Certainly a lot of interesting findings will come out of this, but I think probably what a lot of the clinicians in the audience are going to wonder is, what about the tools we have right now and things on the near-term horizon? So where are we at with being able to modify the disease process, or, thinking of the amyloid hypothesis and some of our anti-amyloid treatments? Have we learned how and where to deploy them? Where would you say the state of the art is now?
I think the state of the art is somewhat unclear in terms of its benefits. So the way you phrased the question is important in that it implied a single unitary hypothesis. So for a moment, let's assume that Alzheimer's is one disease and the amyloid hypothesis is the way it is. And the amyloid hypothesis basically goes that you have this amyloid precursor protein that every cell in the brain, every neuron in the brain has. It processed as part of regular housekeeping of cells to produce these toxic fragments. And these toxic fragments kill neurons, and eventually you go down this cascade of Alzheimer's disease. So the imperative is, let's modify what happens at the amyloid level. Many things have been tried. Let's inhibit the production of amyloid. That didn't go very far. It was toxic in most instances. Let's clear out the plaque with monoclonal antibodies. That so far hasn't been that helpful. Or let's interfere with the process somewhere between the production of the amyloid fragments and the deposition in plaque, and the back and forth, appreciating that the amyloid fragments and what's in the plaque are in a dynamic equilibrium of some kind. So that idea so far, when applied with the drugs that have been developed in more moderate, mild to moderate, or more severe stages of Alzheimer's dementia, has generally removed amyloid, which most of these drugs have been very effective at doing, not really benefited the symptomatic expression, not changed the progression of the disease. The last couple of years, we've seen some of the more novel therapies, aducanumab and lecanemab. Aducanumab in 2022, lecanemab in 2023, approved on an accelerated approval pathway of the FDA by virtue of the fact that they clear amyloid from the brain quite effectively. And yet aducanumab, at least in the research that we've seen published, has not clearly changed the symptomatic expression. And I should say this is in people with very mild symptomatic disease, what we call MCI or early Alzheimer's dementia. So in those people, aducanumab clearly removes amyloid, is of questionable benefit over placebo. One study suggesting it's a small advantage, another study suggesting it doesn't. But in both instances, on aducanumab, people worsened, perhaps just a little bit slower than they were to worsen without the drug. Similarly with lecanemab, bigger study, a little more evidence that, yes, there is really good amyloid removal, but very minimal advantage clinically to patients. And still not clear whether that advantage accrues a little bit like butter spread on bread for a little bit for everybody, or whether there's a subgroup of people who particularly better. And so we could be targeting and get a bigger advantage of lecanemab in some people. The controversy comes from the extent of clinical benefit. So the lecanemab has been especially interesting because, the study was large enough to suggest that there is clinical benefit. But for many of us, it has not crossed the threshold of being minimally clinical important difference to the MCID. Before those studies were presented, there were estimates as to what an MCID would be. If you look at those estimates, the lecanemab or aducanumab don't come close to what the field had said. This is going to be an MCID. Of course, now that they are approved, there's some pressure from certain quarters to change the criteria about what an MCID should be, because these quarters say we need to be more realistic. And, we should just take what we can achieve and go with it. So these are expensive drugs. They carry substantial risks because by removing amyloid from the brain, they seem to create the environment for fluid influx, sometimes hemorrhages in the brain areas, amyloid-related imaging abnormalities. There are hemorrhagic areas and non-hemorrhagic areas. Still don't know where areas go in the long term. For most people, most areas seem to be asymptomatic. For some, they're not. And now we're hearing that there have been a number of deaths, presumably related to areas in some of the lecanemab studies, although we don't know details. And that might be related to patients also being on anticoagulants. So the state of the art right now is controversial. Just this past week, CMS confirmed that also with lecanemab, they're taking the same position they took with aducanumab, which is it's not ready for prime time. They're not prepared to pay for it for everybody. This has created huge controversy and pushback from advocacy groups. And I think the field is in a bit of a standoff right now. Advocacy groups feel like they're being discriminated against. Clinicians like me are saying, I think you're being protected because these advantages are not what I don't interpret these advantages of breakthroughs. And I think most sensible clinicians don't either. We'll have to see. More data will tell. I don't think the story will change that everybody worsens on these drugs. So it's really going to come down to individual patients deciding and possibly having to pay a lot of money to get a very small advantage for a period of time.
Well, you can certainly understand if obviously one of our loved ones had this devastating illness, we would be willing to do whatever we could, of course. And maybe we would even take a delay of the progression of the illness. If not, some degree of improvement would be wonderful. Is it possible that the two parts of our discussion are related? Is it possible that we're not deploying these treatments in a granular enough or precise enough way that maybe there is a subpopulation who would benefit more from this technique?
It is certainly possible. And I think that's, if this is going to work, either we haven't found the right amyloid drug because there's a nuance we are missing in the toxicity of amyloid and we just haven't quite hit the right one, or we're not deploying it at the right time. And maybe we're still going too late. Maybe by the virtue of giving it to symptomatic people, there's not enough time, there's enough brain damage and so forth. So definitely possible. I will tell you, though, that there's one reason, something that is discouraging in that discussion, which is about 5 or 10% of people with Alzheimer's dementia develop it because of an autosomal dominant mutation. These individuals have mutations that relate to amyloid and amyloid overproduction. So if there's a subgroup of people where you would predict that these drugs should work, that would be those people with dominant mutations who are lifetime amyloid overproducers. It'd kind of be a good fit. And so one study with one drug in that population did not suggest that they benefit. And that was delivered years before symptoms. Small study, one drug, a start, but not a hint of signal. So I don't know. Maybe there's a way to define a different subgroup.
That is discouraging. I agree. Well, perhaps then what we're talking about is, either, as you mentioned, deploying these pre-symptomatically would be nice. But of course, how are you going to find somebody if there's not something drawing their attention to you clinically, if there's not any symptoms?
Well, there are prevention trials in the field which use imaging techniques to define older people who have a lot of amyloid in their brain. So we'll be hearing from some of those over the next few years with some of the drugs that we've already seen fail in other contexts. So we'll get a feel. My prediction is I don't think we're going to see that much different. And we'll be confronted with this very big problem. Do we deploy drugs that could bankrupt Medicare if we allow everybody to use them to basically add a couple of years of life in milder stages to our loved ones? A very difficult dilemma.
It certainly is. Well, what other kinds of promising technologies or strategies might there be here then? If so far, pulling amyloid out of the brain and just sucking it out of the brain hasn't panned out as we would hope, is there other ways of thinking about this?
Yeah, I think there are many other. You've alluded to some of them already. This term of diabetes metastasizing to the brain, I had not heard of before. It's very apt. I think there are pathways of looking at diabetes or hypertension or other variables that drive the Alzheimer pathology exogenously as means of intervening. So years back, there had been an insufflated insulin trial. The idea being that if you have peripheral hyperglycemia, because the brain is isolated from the periphery, you end up having hypoglycemia in the brain. The brain manages its own insulin system and doesn't, but it does know that there's peripheral hyperglycemia, so it might overreact and create contained hypoglycemia, and therefore the reduced glucose perfusion that we see on some PET scans and so forth. So the idea of insufflated insulin was, let's produce insulin, you sniff it, and it goes straight into the brain. It bypasses the blood-brain barrier. Unfortunately, that trial, which had a lot of technical problems, did not show a big advantage, although there was a hint, perhaps, of a subgroup of people. So I think there may be a future there if the technical issues get addressed. Insufflated insulin for a subgroup of people with prediabetes, for example, 70-year-old with prediabetes who's at risk. maybe that person could be treated not just with peripheral insulin, but with insufflated insulin.
There is another anti-diabetic strategy that is showing a lot of promise here, and that is these GLP-1 agonists, the glucagon-like peptide 1 agonists, such as semaglutide. As a matter of fact, semaglutide is being studied right now for Alzheimer's. These drugs get into the brain. As you mentioned, the brain is loaded with insulin receptors, and helping neurons perhaps utilize glucose more efficiently, that is their energy source. Also, these drugs have shown a lot of anti-inflammatory and neuroprotective effects specifically. So that may be another promising area.
Exactly, it might. I worry that those GLP-1 antagonists are falling prey to the similar logic that it's all one disease that they are being administered to all comers. We may get lucky, and if there's effect that it might be detected because enough people in the subgroup that benefit might be in the study. So I certainly want to see how that plays out.
Yeah, well, we know that managing diabetes, and certainly these drugs are associated with weight loss, which is a good thing. We know that abdominal fat is pro-inflammatory. It's associated with poorer cognition, particularly in patients with mood disorders. So it stands to reason that perhaps there is a beneficial effect here.
I agree. And so we'll see, hopefully, the trials play themselves out.
Yeah.
So I was moving to the other areas, and I just want to mention vascular and inflammation. So the idea about vascular is pretty good evidence that Alzheimer's process is affected by what's going on in the blood vessels, and it probably has to do with perfusion. And one of my colleagues at Hop has come up with a technique that's basically measures brain perfusion, either on a whole brain basis or on a regional basis using a pretty standard MRI. You sit an MRI scanner. They use a technique called arterial spin labeling. They then administer CO2, which is a brain stressor, and you look to see what happens in your perfusion. And some people with MCI seem to, instead of increase perfusion under stress, either don't increase or reduce perfusion, suggesting that there may be people out there who, for reasons we don't quite understand, but who have reduced perfusion under stress. And those people with reduced perfusion under stress may be a target to at least improve things so that under stress, they have the right response, which is increased perfusion, so that they can then be less likely to develop dementia. That's sort of one example. We use the term vascular brain disease. I think the essence is to get more precise about exactly what we mean there. And I think the idea of perfusion under stress, from my thinking, brings us close to something that mechanistically makes sense as impacting the patholoneurodegeneration cascade. Inflammation is the other thing. The link between Alzheimer's and inflammation goes back a very long time. We actually did a large prevention trial using nonsteroidals. There's been a prednisone trial. There have been nonsteroidals treating MCI, et cetera. And generally speaking, there is evidence that when you have MCI or a more advanced brain AD pathology, nonsteroidals can be harmful. We can talk about why that would be the case. But earlier in the pathologic places, for some people, they may be beneficial, which sort of raises the question back to the stem cells. Can we understand through study of microglia function across many individuals if there are people whose microglia are particularly overreactive with age or with stress? And then how can we modify that? There's actually a company out there that's producing a drug that corrects microglial overactivity in a small group of people who have hyperactive microglia on a genetic basis. I think that's the kind of concept that we'd like to see. Their point of view is if this is 5% of the people, but we can stop the abnormal inflammatory change, maybe that's a good thing. You know, if we're going to have to do this 5% of people at a time, why not? And of course, so that will be the other kind of general tau therapies are possibilities. There are many of those. We don't have that much time left, so I don't want to get too much into that. I do want to mention, Andy, one other important area, which is sleep. So the more we look at it, the more it looks like sleep is a major risk factor for dementia. And you might say, well, is this all about sleep apnea? And sleep apnea is certainly in the picture, but it's probably about the loss of what's called slow wave sleep. This is deeper sleep that we all have, which seems to be the restorative component of sleep. With aging, there is a reduction in the time we spend in slow wave sleep. And that seems to be the critical piece that predicts the link between sleep and down the line. So sleep apnea is one way of getting less sleep, slow wave sleep, but there are other mechanisms. So again, colleagues at Hopkins are looking at that with widely used antidepressant. You've heard of it, trazodone. Trazodone appears to be quite beneficial to slow wave sleep. And so they're asking if you have MCI and less slow wave sleep, can we change your outcome by treating you with a little bit of trazodone?
Well, that is fascinating. I'm wondering what effects the dual orexin antagonists might also have in this area.
Yeah, I think they actually looked at them. I don't remember why they chose trazodone. Pretty sure the orexin antagonists improve slow wave sleep as well. But they may have a role.
So, yeah. Yeah. No, who knows? Yeah. Well, you've opened up some other interesting doors. I mean, I'm going back to your overactive microglia, and it just makes me put two and two together here and think about the stem cells that you talked about, and I can now grow your microglia and my microglia and see how reactive they are. And you're right. And perhaps we put all these things together, these technologies.
Yeah. I think eventually they will converge.
That is remarkable. And again, it gets back to this idea of not just a targeted drug, but perhaps targeted interventions more broadly. Perhaps some folks with Alzheimer's have more of a pathology that's related to sleep somehow, and so we could attack the sleep. Some have more glucose regulation, insulin regulation. Some are more the inflammatory, and so we can maybe personalize on those bases.
Yeah.
You know, Kostas, this is actually my 30th anniversary this year. The first study that I was ever a principal an investigator on, I should say, was 1993. So this is my 30th year of doing clinical trials, and for all these years, we've really been focused on genetics. I always draw an extra tube of blood to send to the lab for pharmacogenetics. And while it's a powerful tool, potentially, the genetics of the brain are so darn complicated. And so it makes me think that maybe we need to be looking more broadly at this idea of precision or targeted therapies.
Yeah, I think you're right, Andy. In the cancer field, where they can access tumors, as you pointed out, and get DNA much more quickly, genetics is playing a more major role. I think, though, we're going to have to, because, as you said, the brain's genetics are so complicated, I think we're going to have to back into genetics. So if we learn from stem cells or other methodologies, if we learn that there are particular individuals who, say, have less active serotonin systems or more active microglia, we'll have to use that information to go back into the genetics to see what are the genetic determinants of that? Because our ability to do the genetic studies, the sample sizes that will be needed to do this is going to be very hard. And of course, we haven't even mentioned CRISPR, which would be the technique that gets us there. So CRISPR, of course, is this way of modifying DNA in a cell.
Yes.
Not in my brain or your brain quite yet, thankfully, Andy. But if we have people with overactive microglia, then using CRISPR, in other words, modifying DNA in a targeted fashion to see if that overactivity persists or goes, that will be a way of getting to the genetics.
Yeah. You know, I think combinatorial approaches are showing a lot of promise. I'm working with a couple of companies that are looking at combining neuroimaging along with perhaps genetics and big data, and then clinical biomarkers, and even things such as digital biomarkers. You know, there's a whole bunch of digital data that can be collected. For instance, using your cell phone to show how much are you texting your friends, or the GPS will tell me how much you're getting off the couch and things like that. You can use the phone to listen to your voice and record the prosody of the voice, analyze the prosody of the voice or your facial expression. So putting a lot of these techniques together might get us somewhere. So thinking in a much more nuanced way and more complex way about, quote, biomarkers.
Yeah, very good point. These digital biomarkers are going to be very interesting. They're a MacArthur Genius Award recipient, MIT, Dina Katabi, who is sort of perfecting the touchless monitoring and the development of digital biomarkers. There's a device, this is a little bit fantasy, but I think that's the target. There's a device in your house that doesn't touch you, that can keep track of all these things that you talked about, but also might be able to keep track of other things like your breathing rate and who knows what else. Maybe you just wear a simple device that's talking continuously. Now, we're getting into sensitive space here because we're going to be monitored all the time, and there's a whole other set of questions. But I think you're right. So the digital biomarkers are bound to explode in the next half decade and will be much more part of our lives.
Well, I'm certainly already seeing them being employed in clinical trials, even industry-sponsored clinical trials. There is this EMA technique, for instance, ecological momentary assessment, which, again, is sort of monitoring you in real time, whether it's using your cell phone or pushing out, questionnaires to you in real time, rather than me seeing you a week or two later and tell me retrospectively how your week went. This is getting you in real time. And so I think this is much more precise data as well. And the FDA is willing to look at this, willing to accept it. Well, let's bring this back to Alzheimer's here. Tell me a little more about what you're doing at Johns Hopkins. There's a precision medicine center. And how can we think about how this is going to relate to Alzheimer's, this concept of precision medicine?
Well, I think ideally we want to be able to define a set of subgroups, each of which will have a therapeutic implication. We're doing it in many different ways. One of the big projects of our Precision Medicine Center is learning from the electronic medical record, using the widely used Epic medical record system. At Hopkins, our wonderful engineers, computer scientists, have figured out a way to extract data from Epic into a protected confidential space of where analyses can happen. And so now in our Precision Medicine Center, we're able to analyze medical records from hundreds of thousands of patients at risk or with dementia. And it's not just looking at things like what medicines they take or other clinical outcomes. We're actually got a bona fide effort to take MRIs that are acquired, which, we're all used to seeing visual reads of MRIs, but there's so much information that we leave on the table. So we're trying to capitalize on clinically acquired MRIs, do a digital read with quantification of things like how much white matter changes there, what are the various volumes of different brain structures. So that's another thing that we're doing, but it's all in trying to understand, can we define a finite, therapeutically relevant set of subgroups of people in whom we should be testing individual therapies? And that's, I think, makes it very exciting. I should say, though, that we also are very focused in having wins in the immediate future for our patients. So we're continuing to advance our ability to treat neuropsychiatric symptoms with medicines and also not with medicines, right? So with colleagues at Drexel and at UC Davis, we are doing a randomized trial of an app that teaches caregivers how to manage behavioral disturbances called the We Care Advisor. And we also have developed something called Mind at Home, which is a home-based package of interventions, so kind of a care management for people with dementia. We've already shown that attenuates risk of nursing home admission, for example. So we're very much focused on, yes, we're very pleased with that. And we're very much focused then on how do we bring wins today with what we know now by doing it better, doing it more consistently, while at the same time we're working on these curative efforts along with everybody else.
Well, this is terrific. I absolutely agree with you. We should bring all the tools we have to bear here. So we talked certainly earlier about diet and exercise and lifestyle modification. We talked about sleep. I think teaching caregivers how to handle behavioral disturbances is critical. I think deploying some of our medications to treat the neurobehavioral consequences. There is a medication, you're familiar with an atypical antipsychotic called brexpiprazole, which is on the cusp of receiving FDA approval for agitation associated with Alzheimer's dementia. There's a medication being studied, dexmedetomidine, that's a sublingual film, dissolving film. It's right now approved for agitation in schizophrenia or bipolar disorder, but it's being looked at also for agitation with Alzheimer's. There's medicines being studied for psychosis, associated with dementias. So I do think we have to look at those neurobehavioral consequences as well, because they can have such a detrimental impact on the course and on caregivers and loved ones around them and on costs for society.
Yeah. And now to your list, Andy, if I could, I would add a combination of dextromethorphan with bupropion being used to target agitation, and our own work, which I think has a little bit changed the world, which is showing the efficacy of escitalopram for agitation. When we started that out, somebody who developed agitation who needed a medication would almost end up on an atypical with generally benefit, but also big risks. Since we published our randomized trial in 2014, there's been a sea change. And the sense is that almost everybody goes on an SSRI first, which I think is very positive.
Yeah,
because it's a much lower risk, effective. And the piece that I find especially interesting is how in this context, the SRI also reduces delusions and hallucinations. So we've sort of made the point that this is not schizophrenia. This is not major affective disorder. This is a disturbance that's specific to the Alzheimer context. So we're seeing symptom patterns and symptom improvement patterns that we would not have predicted from studying schizophrenia and major affective disorder.
Well, of course, Alzheimer's is much more than just disruption of acetylcholine. We know that you're also losing serotonergic neurons and changing serotonin. So it makes a lot of sense. The other medicine, sadly, I would mention that gets used in this context are benzodiazepines, which we know are really fraught with risk in this population. So that is a big service that you and your group have done, I would say. Are there, as we get closer to the end here, we've talked about the importance of self-care, of things that we can all do now before, hopefully, the symptoms show up. Are there any other thoughts you have on the future of Alzheimer's research that you'd like our audience, clinicians, to be thinking about, to maybe have some optimism and hope as we've tried to give them, that maybe within all of our lifetimes, our practicing lifetimes, there might be some new tools?
I think, Andy, for me, the hope comes from all of the stuff that's going on. And so that promoting and supporting the entirety of all of this, because it's such an important problem, is critical. And there's a barrier that we all face, which is it's extraordinarily hard these days, especially after the pandemic, to recruit people into studies. So if there's one thing that our colleagues could help is encourage people to get in the studies or help getting your patients into studies. It's so important nowadays because it's just very hard to recruit.
Boy, Kostas, I really appreciate your saying that. As someone who has spent, as I mentioned, 30 years as a clinical trialist, I can tell you how important the ability to recruit appropriate patients is. And I do think there's some hesitancy, maybe misunderstanding out there. And so I think you're doing a very good service recommending that our listening audience consider referring patients or being supportive when someone says to one of their patients says to them, I'm considering this clinical trial. What do you think? They're in a position to veto someone's participation. I've had that happen before. So thank you for saying that. I think that's very important because I think there is some very exciting research going on. I think, we are still slicing the amyloid pie here a little bit, but I think that people, as we learn more about the pathology and the progression here, people are looking at some very interesting newer mechanisms and different ways of approaching this. And perhaps some of the things you've talked about with the precision ideas of being able to more individualize and not think of this as a unitary pathology. I love your analogy. It's very much like schizophrenia or a bipolar disorder. I sometimes say there's not schizophrenia, there's the schizophrenias. The brain is complicated. There's many ways for it to go wrong. And, hopefully we'll be able to parse it better. Well, Kostas, believe it or not, the time has flown past. I feel like there's many more things we could talk about. There's certainly a lot more in depth I would love to delve. So you and I can meet up again at some point for a further discussion. I'd love to catch up with you more. But thank you so much for your time here, for speaking with us, for joining us on the PsychopharmaStahlogy podcast here on NEI. Any final things you'd like to leave our audience with?
Well, I want to thank you for a very sensitive, careful approach to interviewing me. It's very exciting. I appreciate the opportunity to get the ideas out there and to share the excitement. So thank you.
Well, thanks very much. You did excite me. You did blow my mind. I have to tell you, with some of these new ideas, these EVs and the stem cells, I'm going to have to look into this more. This is obviously an involving field. Yeah. Well, I want to thank you again. I want to thank you, the audience, for listening to this podcast, another in our psychopharmacology series. Please check our website, NEIglobal.com, for more podcasts in this series and also others. We have many other podcasts beyond this series. We have some CME podcasts and some non-CME podcasts, and you can find our podcasts wherever you get your podcasts by checking NEI Psychopharm or NEI Psychopharmacology. Well, with that, I want to thank you very much for listening and have a wonderful day.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.